Bueno, bienvenidos nuevamente a OFTALMOCORDOBA 2021. Vamos a comenzar con el primer simposio. Este simposio que está organizado por un grupo de cirujanos de la India, comandados por Pravin Badavali y la doctora Nidhi Gupta. Así que van a estar como panelistas el doctor Federico Cremona, Néstor Schuster, el doctor Juan Carlos Ginés y el doctor Nicolás Fernández Meijide. Nuestra primer disertante es la doctora Nidhi Gupta, que nos visita desde la India. Es un gran placer tenerte con nosotros, Nidhi, una gran amiga, una gran cirujana, y nos va a hablar de 10 pasos para preparar el Desect. Adelante, Nidhi. Puedes comenzar con tu presentación, Nidhi.
Dr. Tiziano, hi, you want me to share my screen and start?
Yes, please. You can share your screen. You can start now. Hi, how are you?
Yeah, hi, hello from India, and it's absolutely an honor and pleasure to be here. It's a great meeting, and thanks to Dr. Tiziano to make us a part of this. It was also a part of endothelial keratoplasty learners group, which is an online group for actually transferring the learnings of endothelial keratoplasty from best of the masters. Some of them are here with us, over 100 faculty we have, and you can join us on the Facebook as well. With which I'll just start my presentation. I hope you can see my full screen. Just give me a second.
Yes, it's okay, Nidhi.
Okay, so I'll be talking about in the next 5 to 7 minutes about planning your Desect surgery. And it's always nice to have, specifically this talk is for people who are beginning to do Desect surgery. Nice to have a plan in your mind before you do actually a surgery in the OR. You can actually decide on the first 10 steps before you go into the OR. And that's about doing a good anterior segment examination, going on planning your IOL, having a discussion with patient on the potential vision, with which I'll just start off with saying that you have certain indications for your surgery when you go for a Desect. If you will see, your indications are in patients like Fuchs and PBK are quite simple as compared to cases, for example, which are more complicated are the post-TRAB or the glaucoma patients and patients wherein you have CHED or ICE syndromes, etc. So your preparation has to be according to the kind of surgery you're going to be, the kind of patient severity you're going to be taking in your OR. For cases of Fuchs dystrophy, it's nice to do an ASOCT, which helps you decide on the amount of the edema. And also you can do, which is coming up next, is to do a corneal topography and decide whether you want to go ahead with your Desect or your Dmacc in those patients. The corneal edema, as you see, will be more marked in cases which are more affected, along with the DM thickening which comes in. And you have epithelial separation in patients which are more advanced cases, and they would require definitely a Desect patient. So patients in Fuchs, all patients who are symptomatic, patients with a PACI of more than 650 and an anterior chamber depth of more than 3 mm with a thickened DM can go ahead and do a Desect surgery. A little more complicated are cases of pseudophakic bullous keratopathy in whom you have an issue of visibility apart from other issues of previous scar as well as the subepithelial and Descemet's membrane scarring. Also, what would be useful in these patients would be to see how the IOL has been how the IOL is in these patients, whether it's well placed or you have a subluxated IOL for which you will have to decide for actually removing or replacing your IOL with another one. It is nice in the OPT to debride your epithelium, and maybe you can put a BCL in these patients to actually take a look of the anterior chamber, what are the areas of the pass and how the IOL is placed. What is going to also help you is to do an ASOCT in these patients, wherein you will be able to demarcate whether what scarring you're seeing is actually just the epithelial scarring or it is going down to some amount of stromal scarring. And also in patients wherein you have a posterior Desmet scarring, you will be able to decide on which type of surgery you would want to do, whether you want to do a penetrating keratoplasty, for example, in this case, or you can go ahead with doing a good Desect in these patients. With this much of your planning, in cases in which you have more complicated cases, like I already mentioned, cases of glaucoma, etc., you will have to take opinion of your glaucoma colleagues to decide how you're going to be managing your IOP and whether the patient actually has a potential of vision depending upon the amount of glaucomatous optic atrophy that you already have. Also, you will have to see where are your position of the bleb and the tube for you to decide what would be your graft size and where you will be making your initial incisions. And this is just an example of a similar case wherein you have a tube. If you actually see there is a tube here, and the decision has to be done preoperatively as to what's going to be your size of the graft and where you're going to be taking your main incision and your side incisions for your Desect. This is another example of a failed graft wherein the graft host junction was actually very irregular and the size of the graft had to be smaller than earlier it was decided. So that's going to be very, very useful when you're doing it. A second planning which has to go ahead with your Desect cases is whether you're going to be doing a clear lens extraction or you're going to be leaving the patient with just the Desect alone. And this is one tip which actually we picked up from Dr. Pineda's talk, was that maybe age of the patient is one of the important decisive factors. Whether it's less than 50 years age, nice to go ahead and just do an endothelial keratoplasty. If it's a patient who is above 50 years, it's nice to combine it with a cataract surgery. And you can always decide your IL power depending upon the amount of myopia that you would want to target in patients, especially because you're adding the tissue there. Also, patients, you can combine this with anterior vitrectomy and secondary IL. That will require probably a VR surgeon who's going to be doing the exchange with you. Or if you are a surgeon who wants to do an IL exchange yourself, then it has to be pre-planned. Once you have this plan of what surgery you're going to do in this patient, the second important thing would be the vision potential. In patients where you have a good prognosis are cases of Fuchs and PBK. However, the other cases, there has to be a long discussion with the patient, and it should be reiterated that maybe the vision potential would be affected because of the chronic macular edema that these patients get, and also the optic atrophy in glaucomatous patients. One thing which you can do is to do an iridotomy preoperatively in patients in which you have a good visibility, for you to have a benefit of time saving, having less inflammation, and to be very precise preoperatively. Or you could decide to do a surgical iridotomy during your surgical intervention when you're doing. As I already mentioned, I think counseling goes a long way, especially these patients need to be taken for rebubbling, need to be supine post-operatively, apart from the prognosis that you're going to be deciding with your patients and having a discussion. Something which you can do also in patients wherein the visibility is very poor is to put a drop of glycerol onto the eye, glycerine 1 drop preoperatively in your OR an hour before, and that improves the visibility operatively, apart from definitely having a good glaucoma control and giving mannitol to these patients wherein you're expecting the IOP to be rising. You can also give steroids when you have decided to take the patient to the OR 2 to 3 days before, so that your inflammation post-operatively and per-operatively is far less in patients where you do not actually use steroids. Next would be to go on to the next step, that is you're already deciding on to go with your surgical plan. Nice to have your graft decided, and there are universal criteria of what the type of graft you will be using for your Desect patients. And if you are doing manual dissection and you're not using an automated tissue, it's nice to have your trolley ready with your instruments for a manual dissection. And that has to be done well before you actually go in and do the Desect in these patients. If you're doing automated like we do in our eye bank, we actually prime the eye bank 1 or 2 days before we are actually planning the surgery, and the surgical cut for the tissue is done 2 to 3 hours before, and they write notes onto the to the tissue paper wherein we have all the notes of how the graft has actually gone and what are the areas which have been marked before we receive the tissue in the eye bank. That helps you save time as well. And definitely decide your block. Peribulbar would be more controlled while you're doing these surgeries, which are unpredictable. What would be next would be actually deciding on to where you will be positioning yourself in the OR. I like to sit temporally, but a lot of surgeons like to sit on the head end, and it's nice to prime your team as to where you're going to be positioning your instruments, and nice to have your surgical trolley ready. If you're beginning to do these Desect cases, you are a beginner surgeon, it's nice to have a discussion with your mentor as to what's going to be your surgical plan, and have your patient photographed and discussed, and keep your plan right in front of you for you to go smoothly in your surgeries, and have your team also decided as to what is going to be your steps, and how you're going to be preparing with your team, especially patients where you require IOL exchange or a vitrectomy and unpredictable, while simple cases of PBK could actually go smooth. You've decided your plan, you go inside the OR, you've done your dissection. I think next is to set your trolley, specifically decide what type of injection, what type of graft injection instrument you're going to be using. And once that's done, I think it's nice to be very, very prepared with your light pipe. Cases in India, we do a lot of pseudophakic bullous keratopathy, and we definitely keep a light pipe as a backup from the retina OR for cases wherein we have poor visibility, and really goes a long way for us to give a good view of the anterior chamber when, in spite of removing the epithelium, we do not get a good anterior chamber view. And as I already mentioned, you need to have a good vitrectomy backup. So just to conclude, for the beginner surgeons, when you're planning to do your Desect surgery, have a thorough examination done in your pre-op, have a well thought through plan, put it on your notes, put it in your OR, prepare your team for your seating arrangement, for your instruments. And it's nice to have some visibility enhancing instruments like a light pipe in there, and tailor make your approach for the best of the outcome. Thank you for your patient hearing.
Tenemos dentro de los panelistas al doctor Nicolás Fernández Beijide. Nicolás,
hola.
¿Qué tal? ¿Cómo estás? Que es el presidente del Endotelial Keratoplasty Learners Group. ¿Quieren hacerle una pregunta?
Sí.
Hola, Juan Carlos Ginés, ¿cómo estás también? Un gusto.
It is a wonderful and very complete talk. And I have one comment and two questions, if I'm allowed. I don't think we should routinely move to PK when we have that degree of opacity in the long-standing edemas with fibrosis. And I think you don't as well. But do you, in any case, indicate primarily a PK instead of a Desect? And in what cases when the pathology is only edema?
Yeah, if I've got your question correctly, you want me to answer that what are the cases in which I would actually do a PK, not a Desect in patients of PBK, right? Yes, yeah. So it's one thing which I feel in history is a long-term edema in patients would definitely, I'm expecting fibrosis there. And in the clinical examination, I've already seen that I'm not getting a good visibility despite of me removing the epithelium in my clinics. Then I go ahead and do an ASOCT. ASOCT goes a long way in telling me what kind of a corneal stromal scarring is there, and what kind of Descemet's membrane scarring is also there. And these are the two decisive points which actually help me know that yes, this patient is going to be going for PK. The slide that I showed specifically where I tried to show that the patient had a lot of amount of stromal scarring. I think doing Desect also, those patients don't get a good vision in post-operatively. So nice to go ahead and do just a PK in them and not a Desect.
But these are very exceptional cases, right?
Yes, yes.
The fibrosis tends to be only at the surface of the cornea, and you can remove it intraoperatively.
Yes, yes.
And the other comment or question is, what is your preferred technique of suturing when there's a patient, an aphakic patient with an iridia or whatsoever iris defect? Do you suture the lenticle, or do you hold the lenticle with a suture?
I suture the lenticle. I don't hold my graft with the suture. So when you're using the sheath glide, I feel that it's nice to suture the graft, and the sheath glide helps me to do that even in patients wherein they are aphakic.
So you pass your suture through the tissue?
Yes.
Okay.
Gracias, Nicolás. Por cuestiones de tiempo vamos a seguir al próximo disertante, que lo va a presentar el doctor Germán Bianchi.
El doctor Pravin Vadavali nos va a hablar también desde India, perlas en Desect y Dmacc, así que estamos con él. Thank you.
Adelante, doctor Pravin, ya puede compartir su pantalla y puede iniciar con su presentación.
Thank you. Just wanted to thank Tiziano, Gibrina, and congratulate the entire OFTALMOCORDOBA team for the excellent program that you put together. I've been looking at the website and the program details, and also thank you for having all of us on today to speak about a topic that is very close to all of our hearts. So I will be speaking about the transition from Desect to Dmacc, just like Dr. Nidhi Gupta spoke about how you plan for Desect and why you should transition from Desect to Dmacc. Well, there are several reasons why Desect is a great surgery, but for those of all of you surgeons who are doing excellent Desect, it probably is a great idea that you already are very skilled and you should make the transition to doing some Dmacc as well. There's several reasons, and we'll go through each of these reasons one by one. The first one, obviously, is the fact that when you look at an OCT of a Desect graft, either a manual one or even an automated one, you'll see that this is really not anatomical, and you'll see that there is addition of tissue to the area that you've taken the Descemet's membrane off from. But if you compare that with the Dmacc and pre-op versus post-op, you remove the Descemet's and the endothelium and you replace it with Descemet's and endothelium. So anatomically, it is much more natural than a Desect surgery. Secondly, and probably the most important reason, is the fact that the rejection rate after Dmacc is about 8 times lesser than the rejection rates after Desect surgery. And this probably is the single most important reason why, over the long term, Dmacc probably scores over Desect surgery. And especially if you want to do Dmacc surgery in somebody who's undergone a corneal transplant in the past, you probably will reduce this risk of rejection even further because of the presence of 2 foreign antigens inside the corneal stroma. The third reason is visual quality. You have seen patients who had Dmacc surgery, and several of them have vision that is close to 20/20 best corrected, and it is possible for patients to achieve vision of 20/16 as well. Now, this is unheard of in any keratoplasty surgery, and that's the reason why Dmacc tends to score over Desect as well. And if you look at Dmacc tissues on the slit lamp, you also see that it has a Desect tissues on the slit lamp. You will see that there is a posterior curvature to the tissue. And because of this posterior curvature, there is an induction of a hyperopic shift by an average of about 1.5 plus diopters. And this actually leads to unfavorable refractive outcomes if you're doing cataract surgery or if you're doing Desect surgery after a cataract surgery. Whereas in Dmacc, the IOL power is much more predictable with an average shift of only about 0.5. And that's another reason why Dmacc is more predictable. Visual recovery, in fact, if you look at this patient who's had corneal edema after cataract surgery, and day 1 after doing Dmacc surgery, you see a lot of the corneal edema has resolved. And day 3, you see that the cornea is almost back to normal. This doesn't happen in all cases. But then again, for any corneal transplant, this is probably the closest that you'll get to a perfect refractive outcome. And that's the reason why Dmacc again seems to be better than Desect. And the last reason is when you try to deliver grafts inside the eye and you try and put in a Desect graft, the smallest safe incision that you can use is about 3.5 to 4 millimeters, even with the Busen glide. And this also induces irregular, unpredictable astigmatism. Whereas in the case of Dmacc, You can use a 2.8 incision, which is exactly like how you would do your cataract surgery, and potentially induce less astigmatism in this surgery as well. So what are the differences in the surgical technique? There's several differences, but I'll point out the key ones. The donor preparation in Desect is usually done nowadays with a microkeratome, whereas in Dmacc surgery, the donor preparation can be either a preloaded lenticule that is loaded into a glass tube, or you can do the prep yourself in the operating room just before you actually do surgery. The prep is a very quick method and usually takes about 5 to 7 minutes or so after you've set up all your instruments, and usually results in very repeatable outcomes and repeatable tissue with very little damage to the tissue. And this is one of the great things about Dmacc, is the fact that it needs very little instrumentation to prepare the tissue, unlike Desect, where you need to invest in a microkeratome as well. The Desmet scoring in Desect usually is an area that is smaller than the area of the graft, whereas in Dmacc surgery, the Desmet's area of scoring is usually in an area that is larger than the graft, because you do not want to have any overlap between the area that you have your post-Desmet and the new Desmet membrane that you're putting in, to reduce the risk of detachments in cases like this. The third difference is the fact that in Desect surgery, you tend to make very long incisions so that you have overlap of the internal tunnel with the graft that you put inside the eye. Whereas in Dmacc surgeries, you tend to make very short stab incisions because you do not want the graft to actually come into the vicinity of the internal lip of your incision inside the anterior chamber. And even when you make your main incision, usually the main incision, very similar to a cataract surgery, is also slightly shorter than what you would make with cataract surgery, because you, again, do not want your graft to come into the area where you are putting your graft in place. Marking the graft in Desect surgery, most surgeons don't mark the graft. Actually, only in the initial phase, when we were folding grafts to put inside the eye, used to make a direct mark on the graft. But in comparison with Dmacc surgery, it is vital to actually mark the graft, especially in corneas where you don't have good visibility. You can use any letter, but the advantage of marking is in corneas like you see here, where the visibility is not very good. Unless you mark, you will not know what is the correct orientation of the tissue until you put your air bubble and you can see your mark. Loading the graft in Desect surgery, in the majority of cases, you load the graft with the endothelium on top, and then you deliver the tissue by flipping your inserter 180 degrees and having the endothelium at the bottom when you insert. Whereas in Dmacc, whenever you load the tissue, you do not have control over how the tissue curls, and the tissue will always curl with the endothelium on the outside, and you will inject it and then try to ensure that you unfold it from top to bottom, and that's how Dmacc works. The delivery systems for Desect, there are numerous delivery systems, whereas Dmacc, the most common delivery systems that are used are glass tubes and seem to be the most reliable methods of delivering grafts. Lastly, manipulation of the graft in Desect surgery, it seems that you can do a lot of direct manipulation with forceps, whereas in case of Dmacc surgery, you really cannot manipulate directly your graft, and you will have to use either fluid jets inside the anterior chamber, or you will have to use a lot of techniques of tapping on the surface of the cornea to ensure that you have tissue that unfolds appropriately. So this is how you would treat Desect and Dmacc tissues differently. Attachment of the grafts, usually Desect is very easy to attach. You only need a small air bubble and leave the air bubble for about 10 minutes or so for the graft to attach. Whereas in Dmacc surgery, you need to ensure that you have complete coverage of your graft with air bubble, a good sized air bubble, and leave it in place for a lot of time so that it actually sticks, and make sure that you position the patient as well. So to summarize, the reason why you would like to do Dmacc, there's several reasons, but the biggest reason why you would like to do Dmacc surgery is the fact that it has lesser risk of rejection, and also it results in much better visual quality compared to most other surgeries, and also faster visual recovery and more predictable IOL powers as well. There are some difficulties during transition, but on average, it takes about 5 to 10 cases for you to become a relatively good Dmacc surgeon. So for those of you who are wanting to make the shift, the time to make that shift is now. Thank you very much.
Thank you very much, Pravin.
Thank you, Pravin.
It's been
Doctor Juan Carlos Ginés, de Paraguay, nos acompaña también acá como panelista. Nos quiere hacer una pregunta, por favor.
Thank you very much, Pravin, for a wonderful talk. It's been really, really amazing. And for the guys that are transitioning from the Desect to the Dmacc and the ones who are beginning, what would be still your indication for a Desect instead of a Dmacc?
Well, actually, in cases where the cornea has a lot of edema and you can't see very well inside the anterior chamber, a Desect probably would still be better. Additionally, where the anterior chamber anatomy is not very good, there are a lot of synechiae, pupil is very large, there again, probably a Desect would be better than doing a Dmacc surgery. Also, a patient who can't lie down because you need to position the patient very well, you probably would prefer to do Desect surgery as compared to a Dmacc.
Gracias, Pravin,
Thank you very much,
participación. Muy interesante tu presentación. Bueno, vamos a pasar al próximo disertante, que es el doctor Roberto Pineda, que nos va a hablar de consideraciones de Dmacc antes de Desect. El doctor Roberto Pineda nos visita desde Estados Unidos, es el jefe en la Universidad de Harvard, así que es un gran honor tenerte nuevamente con nosotros, Roberto. Ya puedes compartir tu pantalla y puedes iniciar tu presentación. ¿Estás ahí, Roberto?
Okay, buenos días a todos. Dr. Giobrina, gracias por la introducción. Y para esta mañana voy a presentar mi charla en inglés. So, good morning, everyone. And I'm going to be talking about Dmacc for failed Desect. And these are my, let's see, apologize. These are my financial disclosures, which are not relevant for today. So we know that endothelial keratoplasty has become the surgical standard for treating endothelial-based corneal failure. And although Dmacc is technically more challenging than Desect, as we heard from Dr. Pravin, it has faster visual recovery, better visual outcomes, fewer higher order aberrations, and a lower rate of graft rejection. More recent changes with ultra-thin Desect is closing that gap. So what do we know about repeat endothelial keratoplasty, and what is our experience for performing Dmacc after failed Desect? So Desect grafts may need to be replaced for several reasons. The most common is endothelial failure, which may be immunologic based or just from slow idiopathic progressive cell loss, as well as from subsequent intraocular surgery. The other reason is usually from poor visual results, such as interface pathologies. It's also been recently noted that there is a rise in repeat endothelial keratoplasty, similar to that noted with penetrating keratoplasty in the 1990s. So what does the literature say about repeat Desect and Dmacc? Well, repeat Desect for failed Desect actually has very good outcomes, very similar to that to primary Desect, with similar visual acuity and endothelial cell loss. Likewise, a repeat Dmacc for failed Dmacc also has very good results. Two small studies basically showed that all eyes had good visual outcome with a rebubble rate somewhere between 15 and 29%. In terms of the literature for Dmacc after failed Desect, again, there isn't much published in this area, but several small studies have shown that Dmacc was successful in all cases with, again, good visual acuity and similar between the Dmacc after failed Desect and the primary Dmaccs. Again, here we see a rebubble rate of around 13 to 20% in these cases. So this is another study looking at Dmacc for failed Desect, and again, a small one, but it looked at the histopathology of the removed Desect grafts. And in this particular study, they found that the visual acuity was a little bit less after compared to the primary Dmacc controls. But they also showed that the vision might be impaired because there's deposition of protein matrix within the corneal stroma, as well as stroma to stroma interface fibrosis. And this might be anticipated also during the secondary Dmacc surgery. So what are the considerations for Dmacc surgery after failed Desect? Well, we've heard a lot about visibility this morning, and certainly the Dmacc can be more difficult to perform because of poor visibility. It's important to determine the degree of opacification, as Dr. Gupta mentioned earlier. And, you know, some of the older Desect surgeries, we didn't perform peripheral iridotomies. So it's important to note if the patient has an inferior peripheral iridotomy, which tends to be the standard for Dmacc surgery. And you want to note, again, as Dr. Gupta mentioned, any iris defects or glaucoma drainage devices that might affect your surgery. And also, what is the status of the lens, as this might need to be addressed in addition to the surgery. Also, as noted, the altered stromal interface may affect the Dmacc graft attachment. And we heard about the importance of stripping for Dmacc versus Desect from Dr. Praveen. Obviously, patients that have large iris defects or aphakic or have these glaucoma drainage devices, this may be relative contraindications to performing Dmacc in these cases. So what can we do to put things in our favor for the surgery? Well, anything we can do to improve visibility. We heard about light pipes from Dr. Gupta, but we want to optimize illumination. Obviously, if you have access to a microscope that has intraoperative OCT, that's very helpful. Removing that edematous epithelium is very helpful. Dr. Gupta mentioned using 10% glycerin applied to the cornea. I also use mannitol, just taking it directly out of the bottle, a 25% solution, and placing it on a sponge. Likewise, will also help clear the cornea. And you want to maximize the staining of your Dmacc graft with trypan. Sometimes if you remove the epithelium, applying the hydroxypropyl methacellulose on the corneal surface can be helpful. And as for most Dmacc surgeries, we like to constrict the pupil to prevent the graft from going posteriorly. Removing the failed Desect graft itself can often improve visualization. This can be done with an AC maintainer or under a viscoelastic. You want to score the Desect graft 360 degrees with a reverse Sinski or a scraper of some kind, and then remove it either with forceps through the main incision. And the trick here is not to necessarily strip the peripheral decimes, or at least do it in a somewhat controlled manner, and make sure you construct your peripheral iridotomy before removing the viscoelastic or anterior chamber maintainer. You can use the trypan blue to stain for residual decime membrane or tags. This is, again, especially important if you're stripping decimes to 9 millimeters to prevent that Dmacc graft overlap that was mentioned earlier. Here you can see a case. This is unintentional stripping of the peripheral decimes. This surgeon did not fully score before removing the graft. And as this surgeon is removing their graft, you'll notice the peripheral graft inferiorly is being pulled away at the same time, which can happen inadvertently if the graft is not scored 360 degrees. We hear they're using a scissors to cut the adhesion so they can remove the graft without removing more peripheral decimes. Again, here they're removing this, I think, intentionally, and then they'll put some stain in to see if there's any tags, which you can see a little bit inferiorly here. So again, you want to make sure your graft is well stained with trypan. I do a double staining for 2 minutes each time. Again, the importance of marking your Dmacc graft is emphasized. This is particularly important with more opaque corneas. And then, again, your preferred Dmacc graft technique, whether it's a glass tube or injector or other technique. Here's a case of just a standard removal of the Dmacc graft. Again, usually I like to go around and make sure the graft is completely free before pulling it out. You can then just inject the graft here with the glass tube and open it up. This is very straightforward case. And this graft is not marked. And you can see the visualization's fairly good. This last case is done with an AC maintainer instead of viscoelastic. And again, usually stripping these can be relatively straightforward. If there's a lot of peripheral anterior synechia, it can be more challenging, and you can run into removing the peripheral Descemes, as mentioned. You should take your time doing this because doing it too quickly can result in other unforeseen complications. And again, you can see this graft placed here, and then again, using trypan to look for any tags. And once that's determined to be all right, injecting the graft in the eye. This one does have a mark on it. I'm going to move forward just for the sake of time, but this is positioned in place. Of course, the anterior maintainer needs to be removed before positioning the graft. I'm going to move forward here. So post-operatively, there's really no difference in management for Dmacc after Desect. You're going to use your standard antibiotic and steroid management, standard Dmacc positioning with air. Remember, these cases might have a higher bubble rate than the standard Dmacc surgery, so you should be prepared for that and discuss that with your patient. There may be roles for ROCK inhibitors. There's still ongoing research in this area. So in conclusion, Dmacc after failed Desect is definitely possible. Visualization can be more challenging during Dmacc surgery, so you should plan for additional steps to maximize surgical outcomes. Careful removal of the Desect is necessary to manage residual Descemes membrane. And finally, the Dmacc final vision of Dmacc after failed Desect may not be as good compared to primary Dmacc, but has similar rebubble and endothelial cell loss rates. Thank you for your attention.
Muchas gracias, doctor Pineda, por esta gran presentación. El doctor Nicolás Fernández Mejía quiere hacer alguna pregunta al doctor Pineda.
Roberto, that was a very nice talk. Thank you very much. I would like to know if you could share with us how many Desects do you perform out of every 10 patients you do an EK?
This is a great question. So being at a tertiary hospital, we tend to get the more complex cases. So those are patients that have 2 shunts that are missing lots of irises. So for me, actually, I probably, it's 50-50. So half my cases are Desect cases, half my cases are Dmacc cases. And I think that's mostly just due to the complexity of my patients in terms of having a very large glaucoma service that sends us decompensated corneas that have had many surgical procedures. I think, like Dr. Praveen mentioned, if you can do Dmacc, great, but many of these cases, it's more predictable to perform a Desect.
Roberto, una pregunta. ¿Qué pensás?
Sí.
De los inhibidores, ¿qué es lo que tú piensas en la utilización de los inhibidores ROCK en los Dmacc post-Desect? Nosotros aquí no tenemos experiencia con inhibidores ROCK, no los tenemos comercialmente, pero ¿cuál es tu experiencia?
So we use the ROCK inhibitors with our DWEC or DSO procedures, because these drugs have been shown to help in cell migration and proliferation. There's also some studies looking at the use of ROCK inhibitors with primary Fuchs prior to endothelial keratoplasty. And there's some thought that it may be useful post-operatively. Again, there's very limited data in these cases, but in patients that maybe have more peripheral Fuchs involvement, we think there might be some benefit there. But again, I think it's very early. I just mentioned it strictly as a scientific curiosity at this point, and we don't really have any solid data for its use in routine endothelial keratoplasty.
Muchas gracias, doctor Pineda, por su gran presentación y por su segunda participación acá en Oftalmo Córdoba. Vamos a pasar al siguiente disertante que lo va a presentar el doctor Bianchi.
Continuamos con el doctor Vito Romano, que desde Italia nos va a hablar sobre el manejo en el desprendimiento del Dmacc. Bienvenido, doctor Vito Romano. Lo estamos escuchando, por favor compartimos. Si puede compartir la pantalla. Muchas gracias.
Thank you so much. Thank you so much again. I'm going to share my screen, and I would like to thank you, especially Tiziano, for the invite. Please tell me if you can see my screen and if you can hear me well. Is that okay? Yes.
Yes.
Perfect. So I will discuss in the next few minutes about Dmacc graft detachment. And as you know, it's been highlighted also by Roberto, Praveen, and Nidhi. So the advantage of Desect or the Dmacc over Desect, but there is still some evidence, quite strong evidence, as highlighted by the meta-analysis, that the detachment rate is higher in Dmacc. As you can see from this first plot in the down part of this slide. And so what is the management? Normally you see the patient at a slit lamp, and the first sign you see at a slit lamp is still some edema, and this reflects probably some detachment that can be localized, or edema that could be involve all the cornea, depending from the detachment. The tool that you need is an anterior segment OCT. As you can see in this slide, you can see that on your left side, you can see that there is a detachment of Dmacc. And what you do, you can perform a rebubbling at the slit lamp, and then later on, you can check after 1 or 2 days that is completely attached. It's a procedure that is highly successful, but it has need to be done in a proper way. This is an example of it's a technique that I follow. It's been described by Alfonso Vázquez Pérez as some other colleague of the Murphy Eye Hospital, where with a simple instrument, as you can see, an MBR blade, a cannula, and 1 ml syringe, you have a quite good control of the bubble, and you don't increase the pressure. Why you don't increase the pressure? Because with the MBR blade, when you're going in, you're able to release a little bit of aqueous, and then with the cannula, you can control very well the bubble size and the pressure. The other option being described both by Fogla or by the Terry group, that you can use an intravenous extending tube in order, as you can see the picture on the down right, you can control with the double hand. Probably it's easier. In this way, you inject the air with your left hand, and then you control your needle, let's say your cannula, with your right hand. The OCT give you an idea where you need to go in order to go in the anterior chamber and do not touch the graft. If you have a problem instead, you have a free-floating Dmacc, means that the Dmacc is completely detached and is in anterior chamber. You have a problem, as you can see in the first images, on the A images, where there is a completely edema. You can't see the graft because it lose the dye. And what you need, first of all, you need an OCT to see that. It's not very easy with OCT, but you will have some problem to rescue this graft. You can go in and you can face with this thing, get a slit lamp, but you need to go to the theater, and you can use some dye, but for with an air anterior chamber. Because if you don't do that, if you use just the blue, you have a risk that the stroma will pick up the dye and will become all blue, and it will be very difficult. As you can see in this video, I will show some time of my of the surgery, that you can see that you will have a little bit blue, that it's followed by injection of air. In this way, to minimize the contact of the blue with the stroma, and then after a few seconds, you can see much better the graft, and then you can unfold the graft. For seeing of time, I will go a little bit quicker here, and you can see that you will see the graft here. Here we are. And then you can, in the standard fashion, you can unfold the tissue. So you reduce the anterior chamber depth. So removing the aqueous or the PSS.
Oh, I don't know. I didn't see that.
And then you add that. That's it. And then you can put some air under that. I will show you at the end. That's it. This is a way to rescue. If you don't feel that is good enough to rescue, you can always you need to replace the Dmacc, as Roberto was saying before. What you need to be aware, as Roberto has well pointed before, when you do this desmethorectomy, you need to be it's quite important time. So this picture, first of all, shows that the graft is not completely unfolded, and that this can affect your attachment. Or this one, as you can see here, there is a tag, and this tag can affect again your attachment. And in this slide, instead show that the attachment usually starts inferiorly, and for this reason, you need to ask the patient to move this eye during the 48 hours after, in order to help to create a maximum pressure where the detachment probably will become. So usually it's inferiorly, and for this reason, it's good to ask the patient to help to move his eyes and increase the pressure in that point. Other thing that you will see, that this one of the first sign probably that I can tell you that probably the graft will progress. If you can see this wavy posterior surface, there is a higher risk that the detachment will not attach. This is just to highlight that in a clinical paper, and combined with some lab results, the detachment rate of preloaded pre-stip is higher. We are working on it also with using some AFM, looking at that the elastic modulus and the addition is different. And for this reason, we're looking in the percentage of dextran inside of the medium where the tissue is shipped, and this could be an answer because it's significantly higher, the rebubbling rate. I would like to thank you all the team that we work together on this thing, on the Dmacc and the preloading and graft detachment. I'd like to thank again Tiziano for the invite. It's a pleasure to be part of the OFTALMOCORDOBA meeting. Thank you again.
Muchas gracias, Vito, por la presentación. Excelente tu presentación. Quiero felicitarte por el paper ese. La verdad que es muy interesante esa nueva técnica que están realizando para el rebubbling. Doctor Juan Carlos Ginés, ¿quiere hacer alguna pregunta?
Sí, muchas gracias, Cici. Thank you very much, Vito, for a wonderful talk again. Let me go for the pearls here. So if you would have to go back in time with the knowledge that you have now, what would be the 1 or 2 pearls you would give yourself?
Back in time to avoid the detachment.
Yes.
Oh, yes. So you need to take your time to do a decimeterexis and avoid any tags. And don't forget to unfold all the graft, because even a small fold could start the detachment. And the second thing is, speak with your patient, tell what you need to do, because this will be a great help to reduce the detachment rate.
Vito.
And one last question.
Sí, adelante, Juan Carlos.
Would you agree that the same as DSO and Dmacc, in my experience at least, when you strip but not scrub the endothelium, the results are always better?
Yes, I think you're right. The landing zone of the graft, if more smooth it is, better it is. Normally, I score in the periphery and I don't scrub or strip, but normally I peel it using a forceps, the VR forceps. So if you peel like when you peel or strip your donor, so you don't touch the stroma, let's say, but you peel the tissue, and normally it works quite well with the MBR forceps maxi grip, and you don't have this problem. I completely agree with you. The landing zone needs to be smooth as much as you can.
Thank you very much, Vito.
Muchas gracias, Vito. Gracias, Juan Carlos. Gracias, Nicolás, por haber estado ahí como panelistas. Muchísimas gracias a los dos. Vamos a hacer un pequeño corte y comenzamos luego con el Simposio de Cornea Colombia, que en unos minutitos más estaremos comenzando.